Welcome everybody to tonight's webinar, Close the Gap. I'd like to acknowledge the traditional owners of the countries in which we, the custodians of the land and waterways in which we work and live. We recognise their continuing connection to land, water and culture, and pay our respects to elders past, present and future. I'd like to introduce myself. I'm Vanessa Harris. I'm the Manager of the Aboriginal and Torres Strait Islander faculty. Through my grandmother's lineage, we're Aliwarra, and the community is Alparula, and we're from the Northern Territory. This evening's National Close the Gap Day, the theme is Community Voices, the Pathway to Justice, Equity and Healing. The National Close the Gap Day, held annually on third Thursday of March, is a significant date in Australia, focused on raising awareness and driving action towards health equity for Aboriginal and Torres Strait Islander peoples. The day celebrates and recognises the strength, resilience and leadership of Aboriginal and Torres Strait Islander communities. This year, 2026, Close the Gap theme is Community Voices, Pathway to Justice, Equity and Healing. It's important to recognise the difference between closing the gap and close the gap. And the difference between closing the gap and close the gap campaign, while both aim to improve health outcomes for our Aboriginal and Torres Strait Islander peoples. The Close the Gap campaign is an Aboriginal and Torres Strait Islander-led campaign that advocates self-determination and demonstrates that community-led solutions work. The Close the Gap campaign was officially launched in 2007 to address the unacceptable gap in life expectancy and other health indicators between Aboriginal and Torres Strait Islander peoples and non-Indigenous Australians. The RACGP, one of the founding members of the campaign held influence and established the Joint Council on Closing the Gap. The formation of the National Agreement on Closing the Gap, as well as showcasing Aboriginal and Torres Strait Islander-led success stories, it also maintains expectations on governments to take action, for example, in implementing the 4 priority areas under Closing the Gap Agreement. The Closing the Gap is the name given to a series of whole-of-government initiatives with the aim of achieving Aboriginal and Torres Strait Islander equity. The goal of the National Agreement on Closing the Gap is to overcome the entrenched inequality faced by too many Aboriginal and Torres Strait Islander people, so that their life outcomes are equal to all Australians. The agreement was developed in partnership with the Aboriginal and Torres Strait Islander representatives and all Australian governments, and the committed governments to working in full and genuine partnerships with Aboriginal and Torres Strait Islander peoples in making the policies and developing policies that actually do close the gap. The agreement is built around 4 priority outcomes, 17 social economic targets. Under Closing the Gap, there are 4 priority area reforms: shared decision-making and partnerships, strengthening and building the community-controlled sector, transforming government organisations, and shared access to data. This year's Close the Gap report presents the clear evidence for community-led solutions, showcasing 9 initiatives across Australia that demonstrates progress in Aboriginal and Torres Strait Islander health, well-being, despite ongoing systematic barriers. The report highlights holistic approaches to well-being, centering family, culture, country as the vital to closing the gap. Real progress happens when communities led and system support rather than obstruct that leadership. The report calls for urgent legislation and public sector reform to ensure Aboriginal and Torres Strait Islander rights, leadership, and recognised and protected in law. In embedding these rights in legislation, strengthen accountability and deliver real, sustainable change. Moving beyond policy promises to action and outcomes. A link to the report will be provided in a post, even email, and we encourage you to read it if you have already haven't read it. The RACGP is the only medical college with its faculty of Aboriginal and Torres Strait Islander health. Our faculty is Aboriginal and Torres Strait Islander led, and our faculty chair, Dr. Karen Nichols, has a seat on the RACGP board. Our vision, led by the Aboriginal and Torres Strait Islander Council and Faculty Education Committee, is to commit to provision of quality, culturally safe primary health care that supports Aboriginal and Torres Strait Islander peoples to thrive and live long. And to have healthy lives. We also work to grow the Aboriginal and Torres Strait Islander GP workforce, and hopefully we'll be celebrating our 200th fellow within this next year. We achieve these aims through advocacy, education, meaningful engagement with key stakeholders, including Aboriginal and Torres Strait Islander and other peak health bodies in government. In February this year, the college renewed its Memorandum of Understanding with the National Aboriginal Community Control Health Organisation, also known as NACCHO. The peak body representing 146 community control health organisations, ACCHOs, across Australia. The partnership reinforces our shared commitment to the quality reform areas. At the end of this webinar, we hope that you will achieve the following learning outcomes. Describe how community-led models of care improve outcomes. Identify practical strategies to enhance culturally safe in general practice. Identify opportunities to ensure multidisciplinary team care and collaborative effectively with local services to provide patient health. This webinar gives you 1 hour of education activities, CPD, and an optional 1 hour of reviewing performance if you necessarily complete post-event of CPD questionnaire. This link will be included in the post-event email and provided on the demand event page. It's with pleasure that I now hand over to our facilitator, Dr. Karen Nichols, and our guest GP speakers, Dr. Noel Dole and Dr. Tim Singh.
Thanks, Vanessa, and thank you everyone for joining us tonight. And it is an absolute privilege to be here and to be able to facilitate a yarn between Dr. Joel and Dr. Tim around the community control sector and other lessons that mainstream general practice can take from community, and how to strengthen culturally safe practice as well as community engagement. My name is Karen Nichols. I'm the chair of the faculty at RACGP, so the National Aboriginal and Torres Strait Islander faculty. I'm Malakawai, so my bloodline runs to Boigu Island in the Torres Strait, and I also have grandfather connections to the Southern Kanju on Cape York, and thinking about mob up that way because there is a cyclone that is about to hit the Cape. So just bearing in mind there are some natural disasters happening at the moment that we just need to share a few thoughts for our friends, family in those areas. I'm going to ask Dr. Joel if he wouldn't mind briefly introducing himself, and then Tim, if you wouldn't mind briefly introducing yourself, and then we can get straight into it.
Briefly.
Particularly with my
I'm Joel. I'm from Cubby Cubby, Kapandingi Mob, southeast Queensland. It's my dad's side of the family, and my mum's actually French and German, so we've got a bit of a mixed breed there. I live on Warramai Wanneroo country at the moment, and work on Warramai Wanneroo as well. I'm in private practice, which I'm a co-owner of at Nelson Bay, and then another at the Aboriginal Medical Service Ungaroo over at Singleton, and a few other clinics that I just run randomly that are probably not as legit as government want it to be, but I don't care, whatever. That's me.
Thanks,
Thanks very
Joel.
much. Yeah, thanks very much, Joel. It's a pleasure to be with you all tonight, and I hope you are all keeping safe in the various weathers that we see around this large land we now call Australia. I'm coming to you from Dharawal country, where I live and work, southwest of Sydney, and I work. My clinical work is as a GP in the Aboriginal Community Controlled Health Service on Dharawal country in Campbelltown, and I work part-time in the faculty as the medical advisor within the faculty, and also have a particular interest in health equity and so-called deep end general practice, which we might come on to later on, which is a particular feature. I think Aboriginal health is deep end practice as well. But it's a pleasure to be with everyone tonight.
Thanks, Tim. And I might get started if that's all right. And I think it's probably important that we ensure that we're all on the same page. And so in typical fashion, I've just changed the order of things without telling Joel and Tim. And I thought we might actually kick off by talking about holistic care. So I teach medical students. There's a very specific definition that we give for holistic care, but on reflection, it is different to what we see when we're talking about holistic care in the Aboriginal and Torres Strait Islander health space. So, Joel, do you mind sharing your thoughts and your experiences of holistic care?
Oh, holistic care. It is what I think of it as it's common sense, but apparently it's uncommon sense now. But it's really in capturing all the aspects of our lives, including ours and our patients as well, because things that our patients might be going through, we tend to go through things similar as well. And so, look, there's lots of models, and those models have seen change. Like, I lectured in Aboriginal health and education when I was a teacher about 20 years ago, and then things will change and all these new ideas and come out. And honestly, I think it confuses people more than anything. But it's just thinking about, like, in a clinical example, you have a patient with pre-diabetes who's overweight, and it's not just think about, oh, we got to get them on metformin and try and scam Ozempic for them so they can lose some weight as well. It's more looking at, what's happening at home, that, what's happening with their diet. Do they have enough money to actually afford, the so-called healthy diet? And, how many kids are they feeding at home? Are they living in a remote community where they're just, access to food and even just water, is that an issue? Is there, are there cyclones happening every 3 months there? Is there stress? Is there constant deaths and funerals and sorry business there all the time? It's taking all those factors that happen in the community and using that knowledge to provide the best care to our mob that you possibly can. I think that's probably, I just came up with that top of my head, so yeah, something like that.
No, thanks. And I'm going to say Tim, like, I mean, that sounds, from a general practice perspective, it sounds like it could be a bit overwhelming if you have to think about asking about the environment that the person is living in, about their obligations. You talked about not how many children do they have, but how many kids are they feeding, acknowledging that they could be feeding their nieces, their nephews, or their grandchildren on top of whoever else they're feeding. So how can a GP, is there any framework? And I guess I'm sort of leading towards that social emotional wellbeing framework, but is there any framework that a GP can use to ensure that they've got the best chance of being able to get this information from their patient?
Yeah, absolutely. I think it's a really good question. I think as GPs, we're well attuned to being holistic or using the term holistic. I think sometimes outside Aboriginal health, it can get sidetracked into testing selenium and serum rhubarb and things and sort of more internal stuff. And for me, holistic is not so much the so there's lots of different terminologies. I remember being taught in the UK where I did my GP training, the biopsychosocial model, and that's fair enough as far as it goes. I think it misses important components of community connection as an aspect of well-being and spiritual connections as a connection to well-being. I think what I've found as a non-Indigenous person working in Aboriginal and Torres Strait Islander health is made me reflect on my own cultural understandings. And actually, when you look at, for example, the Aboriginal definition of health, if you've make sure you all know that definition because it's important for Aboriginal and Torres Strait Islander people. But when I talk about that definition to non-Indigenous people, they all look at it and go, yeah, of course that's health. And I think it's actually a very human definition. No one thinks of our health as purely biologically determined. And everyone will say, oh, I've got stress going on at work. It's making me unwell. That's just understood. And so our patient-centered care, when we're talking to people, is well-being is a really important concept. What is it that makes you be well in the world, that do the things that you want to do? And people will say some of it's my illnesses, but some of it is the house I live in is rubbish, and or my job, I'm being bullied, or I maybe can't afford the things that I'd like to afford. And I think as GPs, we can give our patients, this is what being patient-centered means, an opportunity to say, what is it that stops you from living the life you want to live? And is there anything we can do to help with that? And sometimes the answer is yes. And so I view an annoying part of my role is the amount of time I have to spend out filling housing forms. But it's crucial for people's well-being. And often we can't make progress on people's biological health if they haven't got a fridge to keep their insulin in, or if they haven't got working cooker to cook healthy food on, or they can't afford healthy food. So it becomes part of our responsibility. The difficulty we have is that everything is focused on a biological model. So as GPs, very often we need other agencies and other services to connect people with in order to do those things. And I'd look back to the COVID pandemic and when we were in lockdown, and what was it that was keeping people well? Sort of medication was part of it, but people baked sourdough and they binged watched Netflix and took part in cultural things and made their own videos, because taking part in culture, being creative, making your own food, doing things with your hands is what kept people well, and social connections kept people well. And so that was what people were keeping on doing, rather as well as just, well, I'm going to take my medications, aren't I? And that gives us a clue that that's what people need to live the lives they want to live. And as GPs, we can find out what that is for each person that makes them tick. And that we can do in whatever context we work in, I think.
And I think you touch on a nice point there, which is one of the things that we can do as GPs is help people reach their full potential. And that's part of that NACCHO definition of health. And I just think it's quite lovely to think we can have a role in helping people reach their full potential. I guess I want to sort of shift a little bit if I can. So one of the things about ACCHOs is, their provision of culturally safe care. But in that, it's actually about shifting the dynamic of power. So power imbalances that sort of happen through the nature of, you know, the person with the medical knowledge versus the person who's coming, seeking some advice around something that might be medical. In your consultations, how do you manage that? How do you shift that power imbalance? And I don't know, Joel, if you have some ideas, because you care for quite a range. You've got your youth clinic, and then you work in private practice, and you work in community control. So is there anything that you do that's sort of common that, you know, that you do in the community control sector that you see works well in private practice, or vice versa? This is, again, something that I teach medical students, that they really struggle with, this sort of how to shift that power dynamic. And in doing that, they feel that they're giving something up. So are we actually giving something up?
Look, I think the most important thing is building a relationship, and I guess the best example that I learnt was when I was teaching. Had one of my I was lecturing at uni into the teaching program for Aboriginal health and education as well, and one of the students, non-Aboriginal guy who had long hair at the time, and back in those days, you know, if you worked out in the country and you had long hair, you were called whatever, you know, gender insensitive words you want to put out there. And he really kind of integrate the Aboriginal community, took care of him, and it wasn't so much that he was being bullied and, you know, people were, someone shouldn't bully you. It was more he found a place within that community where he connected, so that, you know, that on that chart you had before, we had social and kinship connections. We have to have that connection ourselves as GPs, or as the, you know, as doc they'll call you, or medicine man, or whatever name they come up for you. You have to, you know, and because you always have this, it can't be, you know, you've got to be confidential and not give too much. But if you don't give anything, they're not going to trust you, because they don't know how you fit into that community, or they don't know. So his example is, you know, one of the guys, one of the dads said, "Oh, you're my son's teacher. My son loves you, you know. So if you have any problems with these fellas, we'll come and sort them out, you know." And so it's just having those connections and knowing where you fit in. So talking about where you live or how many kids you have, all those things show that you're human just like them. And humans, we need to have some sort of connection, or something that brings us both together, no matter what cultural background we come from, no matter what country or language we speak. There are connections there. And I find that's probably the best way to build on it. So when I see a patient for the first time, I just say, you know, "Oh, just gonna, you know, how can I help you today?" And then they say, "Oh, I got this. Yeah, cool. Let's go through a bit of your story, your history," and then I talk about me as well. So, well, this is a bit about me, because you've given a bit about yourself, and I'm going to tell a bit about me. And so I find that just, you know, levels it out. It just levels out, because in Aboriginal, you know, cultural society, no one was better than another. We all had roles to play, and as long as you stuck to those roles, you know, there was that respect there, and everyone had that respect. That's why we had talking circles and not a lecture theatre. That's why we have, you know, when decisions got made, it wasn't outvoted. Everyone had to decide, and that could take weeks or months or years. So we all have an equal value, and I think if you go into a consult where you see people as equal and actually give a bit of your little bit of your information and your story, you'll definitely go a long way in that building that relationship, even from the first consult.
And I really like that. I mean, you've talked about building trust, building connection, the sharing, that two-way sharing, so sharing information about yourself, and clearly it's got to be stuff you're happy to have in the public arena. You don't divulge anything too personal, but I love the way that you worded that, seeking the patient's story, because everyone has a story, and everyone likes to feel heard. I guess, Tim, from your perspective as a non-Indigenous man, like how do you build that connection, and I guess maybe reflecting on how you felt when you first got into Aboriginal Torres Strait Islander health, doing that two-way sharing versus how you feel about it now?
Absolutely. And I think I certainly was wary of that two-way sharing. And there's still some moments where like patients will say, oh, how are your twin daughters doing? Oh, well, I'm not sure I want to give out too much information about them. So, but that sharing has always been an important part, and I've become happier to do that. And it is a way of leveling out the power dynamic and I think one of the things that working in Aboriginal health services has taught me is understanding my own cultural influences. And so what I've realized, and actually our own professional culture, which has words like compliance in it, and this understanding that what we're trying to do is tell people what to do and they should obey us. And I've completely changed my understanding of that. I don't find that useful. Like my understanding of the history of colonization is that for over 200 years, we've tried telling Aboriginal and Torres Strait Islander people what to do, and it really does not work. And we've got strong evidence for that. And that actually what we should be doing is not telling people what to do, but enabling people to make a decision about their life that's the best one they can make based on the information available at the time. There's some, and actually Michael Marmot, I've pulled this up to remind myself, he wrote a lovely editorial years ago in the MJA. And the headline thing is, health is dependent on conditions that enable people to live the lives they would choose to live. So that's what we're trying to do, is enable people to live the lives they would choose to live. If someone, so I'm not persuading someone that they should or shouldn't take statins. The number needed to treat is what, about 84? So like some people will definitely benefit from that, but some people will say, those odds, I don't want the diabetes associated with it or something like that. And so it's, what decision are you going to be happy with given the information we've got at the time? And it's enabling that. And I think came across in the UK, I think it was Trish Greenhalgh, this wonderful concept of a consultation is a meeting of two experts. And so I'm the expert on the sort of things that work in healthcare, the sort of the biological things, the knowledge of trials of what works on average for the most people. But my patient is an expert on what their resources are, what time they've got, what their values are, what's important to them, what they want to achieve. And so together we can negotiate that from our different perspectives and negotiate a really strong way through that doesn't negate either of us, but gives power to the patient for decision making. Now, that doesn't mean someone comes to me and asks for opiates and I say, oh yeah, here you go, have lots of oxycodone, because that doesn't allow people to reach their full potential. But we can have a negotiation about how we reduce that dose so that they can reduce their full potential. It doesn't negate the legal obligations or the professional obligations on us, but it does mean that we're actively developing a relationship which is healthy for the patient and actually is much more satisfying for us as GPs. The important thing for us as GPs is that's core to our profession. That's, you can all do this, like, because you're trained GPs, and that works really well. But we can consciously say, hang on, we have institutional power as GPs, even when it doesn't feel like it, but we're going to hand that back so people have control over their own lives.
And there's a wonderful resource, just sort of in the interest of time, there is a wonderful resource called Finding Your Way. It's a shared decision-making tool. So if participants want to Google Finding Your Way, it's a shared decision-making tool, and it goes through a process on how to ensure that you're empowering patients with shared decision-making. It is evidence-based. It was developed during COVID to help Aboriginal Torres Strait Islander people in New South Wales make a decision regarding vaccination, but it's been used in cancer treatment settings. It's been expanded. So that is a useful tool to help with that. I do want to move on and just ask about cultural safety, if that's okay, if we don't mind, we sort of head in that direction. There's always a lot of talk about culturally safe care and how doctors need to become culturally safe. I find it a very overused term, and perhaps a term that's not used in the way that it was originally intended. I guess Joel, if you're happy, unless you want me to go to Tim to start to give you some thinking time, that's okay as well. Culturally safe care. So what could GPs do to enhance the provision of culturally safe care? Big question.
So yeah, no, look, I guess you're right. Cultural safety came from Aotearoa, New Zealand, about 20 years ago, and it was a pretty distinct definition where you just look, you from a cultural perspective, you try not to judge people, think about your own judgments and biases, and just try not to offend people. That's pretty much in a nutshell what they were trying to do at that time, and it's kind of developed into more documents. But look, it's to me, it's just, don't be racist. It's simple as that. And I know, look, I drop the R word all the time, and and a lot of non-Aboriginal people don't like the R word or being called racist. But if you can't see something from another perspective, from a cultural perspective, then you can come up with any word you like. But if you can't, especially when in Aboriginal communities where we've just been attacked for every reason, and a lot of our cultural heritage hasn't been lost; it's just been misplaced and removed forcibly, and I think, I guess going through the definition of what culture actually is can sometimes help people. So I guess the simplest definition, because simple means it's complex, I guess the simple way to explain it is more complex than what it sounds, is how people interact with the world around them. That's probably the best definition I've ever come across on what culture is. And then you put that specifically with Aboriginal people, or Koori, Murri, Guri. So even Aboriginal is, even that term is probably inappropriate in the fact that it's not original, where Aboriginal is in abnormal, and then you've got Indigenous, but Indigenous to where, and doesn't define our people. Whereas we have our own language groups of Koori, Guri, Noongar, Nanga, Bama. I wrote a song about it, but we have our own ways of describing things, and for me, cultural safety is knowing that knowledge and that understanding of even just the language groups that you're working in. So if you're, roughly, if you're working in New South Wales, most people are Kooris or Murris, or Murris if you go up the top, but then Guris if you go down further towards Victoria. So those little things like that, I find, I guess a lot more beneficial. And when I do my referrals to specialists, I always say, this is a Koori fella from Warramai, and I just put that in there. Then I put in brackets First Nations, just so they understand what I'm talking about. and even First Nations, I don't even understand that one. But anyway, I remember me and Calvin Kong were having a joke. He'll probably get angry with me for saying, but we're going to do this shirt, say the effing people. First Nation for effing. Yeah, you know what I'm talking about. If you don't, then yeah, you probably need to hang around more blackfellas and have a listen to our humour. But yeah, and even humour is another. So I did this research in when I was fourth year med student, and we just had our fourth baby, me and my wife, and same wife to all the kids, and I thought, I better stay home for a bit. And so they said, do this research project, and I said, what's the research project? I said, whatever you want. I was like, all right. And then I was doing a lot of film work, and then some elders in Maori hit me up to do some stories about some of the elders there. So because they had the pool, all the bus rides, and there's so much history in that place. And I started filming all these uncles and aunties from Maori about what culture is to them. And there was kind of five themes that came up. One was loss of culture. That was a culture in itself. The culture of not knowing your connections, or not knowing your family kinships, and your skin colors, and how you fit in, and which environment or which town and country that you're supposed to take after. And so that was part of it. So that loss of culture and loss of identity was a cultural thing in itself. The interesting one, just in a matter of time, was the humor, and humor is used so complex. It's hard to explain. So even though we'll joke and laugh about it, it's serious at the same time, and sometimes people don't understand that, and it's a whole story that, you laugh and you cry. They're both similar emotions, and for Aboriginal people, that's, instead of crying about it, we'll just make a joke about it, and that can be taken the wrong way, as in, they mustn't be too worried about, uncle die. Oh, he's going to die anyway, and we make a kind of joke and whatever, and you think, oh, maybe they're dealing with it okay, but the joke in itself and the humor in itself is actually saying that, yeah, I might not be coping as well with it, or and it's okay to say, oh, look, I heard you had a bit of a joke there, a bit of laugh, but I just want to make sure that that is there anything more serious to that, to that statement or anything like that. But I guess you don't learn this from a book. You learn this from talking to mob. You learn this from going to community. You learn this from home visits, going to home visits and seeing where people are living, and how the family interact with each other. And the more mob you talk to, the more you pick up on all these little, these cultural safety, really. Yeah.
No, thanks for that. And I am interested in the five cultural things, because the loss of identity is a thing, and I think that's underappreciated. Tim, I just wanted to ask. I mean, the photo that's on the screen, I think for me encapsulates cultural safety, which is it's not about the other, it's about the self and reflection. And it is what Joel has touched on about understanding what culture is, but understanding what your culture is, and how your culture can, how it can impact others, and how it can come through your work. And, the way you communicate, the way you interact, all those sorts of things. I guess it could feel like a minefield for doctors who don't want to do the wrong thing, and they want to practice in an anti-racist way. How can, and I will acknowledge, we have a lot of doctors who are very well intentioned, and mistakes happen. What's your advice for those doctors?
Yeah, I think that's such a good question. I think we can get really scared of making mistakes. My experience, and I've made so many, and I can't tell you how many times the Aboriginal health practitioners that I work with have stopped me from making worse mistakes as well. Which goes to Joel's point about talking to community members and people in the community, and colleagues. But people are really forgiving of mistakes if you're honest and open and real about that, and accepting of of people commenting on that, or being humble and accepting guidance about it. People don't mind you making a mistake if they see that you're making an effort. And so I think we actually don't need to be as frightened of getting it wrong if we acknowledge that we sometimes will get it wrong. And I think, as Joel said, one of the central things is, so I couldn't agree with you more, Karen, that the idea about actually cultural safety is knowing our own practice. So I'm working in Aboriginal health has made me feel more English than I ever felt in England, because it's made me think, well, what does that mean? And it's really made me realize my Englishness is Northern English, working class Methodist family. It goes back generations. And it makes me realize how strong an influence that's got on me and my sisters, and how that plays out in what I think is important about the world. And gives me the realization that that experience is not true for everyone. So I can expect that my patients will have had different experiences to me. I can expect that they will have had terrible experiences in health services, and they'll expect another one with me. And so I do everything I can to say, That's not going to happen in any health service that I have any control over. That might just be my consultation. If I'm a registrar, that's what I have control over. But in this consultation, it will be a good experience for you. I'll do everything I can. And being an advocate, so in our referral letters where we're referring to someone saying that, oh, they're a First Nations patient, or they might have missed the last patient because there was a funeral. That's really important. And some of those bits of advice. Other times where we tried to switch someone to insulin because their diabetes was out of control, and we discovered that she was on a mission as a child and was given forced needles that she remembers as being really painful. She's been adamant she didn't want needles. Now, I wouldn't have guessed that, but it's part of understanding the history that's so completely different to mine that you only get through talking to patients, talking to community about these sorts of experiences. So I think cultural safety is this really big term, but actually it's about understanding our own cultural influences and that the people in front of us may have had different ones, and being curious about that and interested in that, and then guiding them through their own story.
And I mean, we talked about that that patient and the insulin a few days ago, and it highlights to me that no amount of knowing detail of Aboriginal practices, cultural practices, would have actually provided you that information. It's about knowing the history and having that rapport and shifting that power so a patient feels comfortable to share what is the real barrier here. Yeah, so I think that's quite a powerful story. You've both sort of touched on the role of connecting with community, and perhaps in some ways that helps clinicians be a little bit safer in terms of provision of culturally safe care, because you've got connections, you can get advice, you can get mentorship, whatever else, but you really got to put yourself out there and sometimes that can take time. You've just got to keep showing up even when you feel that people don't want you there. You got to keep showing up, because one day they'll go, yeah, they really want to be with us, so let's they've earned their stripes, so to speak. I guess Aboriginal community controlled organisations employ Aboriginal health workers and practitioners, a unique workforce not found anywhere else in the world. So I think it's a workforce that is a solution to a problem. And this is when Aboriginal and Torres Strait Islander people were not allowed to engage in healthcare or access healthcare. And I guess the other thing about ACCHOs is they're multidisciplinary teams. And maybe, Joel, you can talk about how can services engage with Aboriginal health practitioners, multidisciplinary teams in a way that will be impactful for their Aboriginal and Torres Strait Islander patients.
Yeah, just refer them. No. Yes. So Aboriginal community controlled health services are really unique in that they have a board of community members that pretty much decide we need a speech pathologist, or we need an occupational therapist, or we need psychologists and a mental health team, or we need some specialists, and then they will find some money somewhere with a whole bunch of grants or whatever they do, and they will actually hire them and get them to work there, and no other practice really does that, and the most important are the Aboriginal health workers. That you won't, these are members of the community that are kind of bridging the community to the health service. Like, if you can get access, that's what they're there for. If you're worried about a patient who's who lives out somewhere and you're not quite sure, or you're worried about whatever, you just talk to them, say, no, I'll go visit them, I'll give Arnie a call and see how she's going and have a good chat to her. Or I think that job role is like one of the best ideas that have ever come out of health, to be honest, because of that fact. And for me, especially in Aboriginal medical service, you gotta, as a GP, you train them up. Like, I'll use if any of them are interested in doing, excisions or whatever, I said, come and watch, come and help, we'll get the patient's not going to mind. And then just little things like that, so that because they're your best group to become the next generation of doctors for that community. They're your best community people that you can pretty much, they're keen, and they're happy to train if you show them how. And even just by saying, oh look, you'd actually make a great doctor, why don't you think about doing it? And that has a massive impact on people. Even me, even though my old man's a GP, a doctor as well, like I was like, I'm never going to do doctor stuff. That sucks. So I did teaching and all that sort of thing. And then I was lecturing at Newcastle Uni for years and years. And then one of the associate professors, like, he's like, Joel, just go and be a doctor. You'll be great. And I was like, all right. Simple as that. Like it wasn't, I knew how much work you had to do to get through, because I saw what my dad had to go through when I was in high school. And I knew, and I just didn't want to do it. But then, someone saying that says, I see something in you that, could do great things. It's not saying, oh, you make it. You should become a doctor so you can whatever. It's more that you can really make things better for people. So and those Aboriginal health workers are you dead set the best people you can get, and you're only as good as your team. Like if you can't have anyone, if you don't have anyone to refer to, or any specialists that that so we're at Singleton. So I was a student at Maitland Hospital for years, and an intern and resident there at Maitland Hospital, and one of the cardiologists had just become good friends. And I don't think he remembers who I am now, but I send all my patients, and he bulk bills all of them for all their echocardiograms and everything, and he just gets it done, and really quick, and to provide the best care for our patients, we need good people that we can refer to, and those allied health, from podiatrists, so people that you actually kind of trust, and that that they're going to go there and not be offended or looked down upon because of whatever background they're coming from at all. It's really important. But yeah, anyway, that'll do.
Thank you. And I think you make an important point there with regards to who we refer to. It's got to be someone we trust. Sometimes that can be hard to work out who to trust, and especially if you're new to an area, it can be hard. So asking around, but the other thing can sometimes be that word of mouth. One patient comes back, you send a patient to someone, they come back and they go, they were awesome. And, so you can get a sense. Tim, just really briefly, what's your experience been like with the multidisciplinary teams and health practitioners in ACCHOs?
Yeah, so really good. We have excellent health practitioners. We've just trained up some more as well, and I think it's one of the reasons that working in ACCHO can be really satisfying as a GP, because there is a team that surrounds us that's working together with sort of similar values for the community, and the community control is so crucial. It's like sort of I'm employed on behalf of the community to provide care for them, like the other groups are. The need is recognised pretty much in Aboriginal health, so it's not really well funded, but there are ways of getting specialists involved and allied health involved, and we have an excellent relationship with our local university. So we have podiatry from the university department, we have some of the medical school specialist teachers provide specialist clinics to us, as well as other pathways. So there's a lot of sort of imagination around that. That doesn't mean it can't be done outside ACCHOs, I think. And sometimes maybe it can't all be done at once, but little bits are important. I think there are sometimes disadvantages for international medical graduates. The local graduates have come up with a cohort of people who all go through their careers and actually know each other and refer to each other. And I think that can be an advantage that can be used. But otherwise, I think asking around, getting to know your local network. Aboriginal health practitioners can be employed in mainstream practices, and the workforce incentive payments can support that as well. There's nothing like having a welcoming practice that also the community members see community recognizable faces in the service. There's nothing that makes that more welcoming for people, and so Aboriginal health practitioners are the obvious ones, but that can also be true for receptionists, practice managers, part of the team. And my partner's practice has done that successfully. And the other thing to what Joel says, no child goes through my consulting room without having listened to their own heart. And it's just little things like that, and go, oh, did you like that? This is it's really interesting, isn't it? Can be a really nice thing that this is an opportunity for you. You're not excluded from this in future life.
And I mean, planting that seed of what is possible, I think, is critically important, so that it's never off the table. And I just want to remind participants that there is a joint resource, or a resource that RACGP endorsed from NATSIWIP, the National Aboriginal and Torres Strait Islander Health Workers and Practitioners Organisation, on that, how to embed Aboriginal health practitioners into primary care, mainstream primary care. So that guide.
Available on the link in the chat group.
Thank you, Tim. It's always good having someone who's very IT savvy.
Control C.
Yes. Thank you. Now, I just want to remind people to pop questions in the chat. Now, we have 2 questions. I do want to address, well, we have 3 now. I do want to address the first one because I think we've touched on it really briefly, and just it is a comment around how the impact of the referendum on people's health. Do either of you want to just make a comment on that? And Joel, I understand if you don't feel that you want to comment on that. I don't want to, and I'm quite happy for Tim to talk about what the health impacts of that have been. Brings up all sorts of things for me.
Look, I knew it wasn't going to get through anyway, to be honest. I hoped it would, and I hoped that people saw that, but the campaigns were just so confusing, which is what was intended when it comes down to it. It was going to fail anyway. But I guess the effects on health, like a lot of professionals, a lot of colleagues, especially Aboriginal doctors, were pretty upset about it. And the fact that they'd spent so much time working with non-Aboriginal patients and non-Aboriginal people, and on chairs of non-Aboriginal, all sorts of organisations, and then still people, we just don't seem to have that respect was devastating for some people. But like, for me, it was just like, yeah, what else did you expect? This is what happens when people, they're not educated about what it meant and what it was there to do, and there was no real plan. It was to come up with a plan. It was everyone agreeing that yes, something needs to be done, and it needs to come from Aboriginal people, and we're just giving a platform for that to happen. That's all it was, and it just got lost. It got lost in everything. And so specific for patients and how it's affected health, yeah, lots of patients were definitely upset, and but we saw a lot of funding get cut from AMSs, from Aboriginal health programs, and just this, we're not going to do the acknowledgement of country anymore. We're not going to raise the flag anymore, because it was almost this, no one cares about Aboriginal people now, so let's, just get rid of all the stuff that was put in place. And so it's, I think we just learn from it. we don't just survive, we thrive. Mob know how to thrive in situations where everything's against us, and we will, and we get through as best as we can. and you know, you could call it resilience, but we don't have a choice. But yeah, no. Anyway,
Yeah,
that's
and
my
I
two
think
cents.
you know, we have seen an increase in racism, online, interpersonal. I mean, the systemic racism is still there, and racism has very real health impacts. And I would just remind people that there is a chapter in the preventive guide, the fourth edition of the preventive guide on racism in healthcare, and the ACCHO that for this month, the Aboriginal Health edition has an article on racism in healthcare and the impacts. So I'd strongly encourage you to have a look at it. It is a topic that I think if there is a lot of interest as a faculty, I think we would be prepared to do a webinar on that
Yeah,
actually.
and just on that, just on I guess the best, there was so I was doing a lot of things with different countries and mob from all over the world, and there was this one fella from Aotearoa, which is New Zealand, and one of the Māori fellas there, and he had the best way of doing it. He said, look, you know, white fellas don't listen to us mob, but they'll listen to other white fellas. So when white fellas pull up racism and they pull up, you know, it makes more of a difference than it does if we say don't be it. Or, you know, if you just say, oh, look, you know, Dad, that's actually pretty racist, you should cut that out, eh? And just little things like that is what changes things. That's who they listen to. So it's all our, you know, doctors that are listening right now, this is all on you. You got to do it. You got to pull people up and call it what it is when it is. You know, and don't be ashamed to do it, because you get way more respect, and then other people. Because I honestly believe that most of Australia wants to help, and I honestly believe most of Australia are actually got Aboriginal blood in them. They just don't know it. You know, I really believe that. It's just you can't be mixing for 200 years with a group of people and not have some sort of, and if you go to ancestry.com, do your DNA, who someone owns by then. But anyway, you'll be surprised at where it leads you to. But I think you just, if we all start pulling people up and just, you know, calling it what it is. And then that's when we see changes. You know, I don't think online is the place to do it. I think you're just going to have all the trolls and all the people that just want to set things off. It's not a place for it. That's just a place that people vent with their digital psychosis, I call it. So it's not real. So it's psychotic, and it's just ones and zeros. So, but doing it face to face is your best bet. If you see it, call it, own it.
Yep.
Yeah, simple as that.
And one of the comments, which I think is very accurate, is the principles. So the principles that we've been talking about can be broadened to all cultural groups. So being aware of our own biases and our cultural perspectives, being someone who listens to patients, and that's all basic principles for care for all our patients. And yes, completely agree. And, you know, Peter O'Mara often says that if we do Aboriginal and Torres Strait Islander health well, then we probably do health well for everyone. So there's lessons to learn and share and practice widely. Tim, there's a question here. Do Aboriginal medical services also have the allied health staff on site?
It is really variable. It depends on the service. We've got quite a lot on site. We're a relatively large now, grown over a decade, the last sort of 20, 30 years. But there are some which are much smaller, which would have much less on site. And so it's really variable. Many will be using the local allied health, as many practices would be as well.
Yep. And it's 8 o'clock. We have run out of time, but Joel, there is one question. I'm just wondering whether this would be something you'd be happy to briefly talk about, because I think it's important. Could you please make some comments on how to orient health assessments to community perspective rather than the doctor's perspective?
So the Aboriginal 715 health assessments, the approved one that was done through NACCHO at the time, I think, yeah, that's the one that was made by Aboriginal community and NACCHO anyway. So that covers most things you need to do. Really, I haven't found any problems with that one. It goes through. It doesn't do much on environment and housing and things like that, but it does say, are you safe at home? Is there, and it allows you, is gambling a problem for you? So it does a whole range of that holistic, and in the matter of time or how long you can actually do a consult for it, or get your nurses or any Aboriginal health workers do. It's a good guide, and you can actually, I guess, extend it if you needed to, but that's the one.
There's a
The
new
one
template.
before that, sucked. Yeah.
There's a new Prince way which does it even better, I think.
So yeah, there's new templates coming out. So it will be updated, but it's about knowing your community as well, and knowing what those health issues are in your communities. But yeah, thank you for yarning with me tonight, Tim and Joel. I'm going to hand over to Vanessa.
Thank you, Karen. Look, great yarning. Thank you very much for the panel. It was so interesting. And I thank you, Karen and Joel and Tim. I think it's been a really lively, interesting conversation tonight. I'd also like to thank our attendees who logged on this evening and to listen to our yarning, and to thank you. And if you have any more questions, please feel free to reach out to the RACGP Aboriginal and Torres Strait Islander Health Faculty. We'd be only too happy to follow up and answer any of the questions you might have. So thank you, everybody, and good evening.